Die Wohnungswohnung.
I don't know if any of you have been in a situation I found myself in, that you're asked to give a talk on a subject and you're given a title and it's many months before the talk and you say, that's fine. Then as the talk draws closer, you think, did I really agree to talk about this? And the solution to my dilemma, because I am not an ethicist and know indeed very little about ethics, came when I asked to see the list of people who are coming, because I realized that we have an audience packed with people who know about ethics. So I'm going to address this in well under my allocated time, talking as a humble general practitioner and talking to you about some of the issues that have occurred in financial incentives being introduced into clinical practice, and then hoping to open up a discussion around some of the ethical issues attached. So I'm going to talk about, first of all, the fact that maybe it will come as a surprise to some of you, I hope not, but that variation in medical practice is ubiquitous and that there is substantial variation in quality, and that financial incentives have been used as one of the ways of trying to close the gap between what we could provide in medical care and what we actually provide, and point out that these have been partially successful but also bring with them unintended consequences, and then open up a discussion of what the ethical issues involved in that are. So first of all, variation in medical practice is ubiquitous and was demonstrated really by a whole series of studies from Jack Wenberg in Dartmouth in the 1980s that demonstrated that doctors often don't do the same thing when faced with the same clinical problem. But what then became, crystallized this into a different form, was the demonstration in the 1990s that variation in clinical practice often also meant variation in quality of care. So the notion that what a doctor did must be okay because he was a doctor suddenly went out of the window. And if I give you an example, a very striking one from Beth McGlynn's work, which really made a major difference to how people understood this field. Beth did a huge study in the United States when she developed 430 quality indicators for 30 conditions, developed by 49 panels, applied them to nearly 7,000 randomly sampled US adults. And what she found was that for chronic conditions, around 60% of patients were receiving recommended care, 20% of patients were receiving care that was contraindicated. For acute conditions, 70% of people were receiving the recommended care, but 30% were receiving contraindicated care, and preventive care, only half the people were receiving the care that they should have done. And this led to the publication of a very influential book from the Institute of Medicine in the US, Crossing the Quality Chasm. How could we cross that gap, the big gap, between what could be or should be provided and what was actually being provided? Now, if you accept those first two things, that quality is variable and quality needs to be improved, then the question I want to address is, why would you choose pay for performance, financial incentives for quality, as a mechanism to try and bridge that gap? And there are essentially two reasons why you might try and do that. The first is that it might simply cost more to provide high quality care. But the second, and the one on which we're focusing today, is that it might provide an incentive to doctors to improve their care. And so we want to consider why you might even consider offering doctors an incentive to improve the care that they provide. Now, I'm going to talk to you about a UK experiment in providing financial incentives to improve quality of care, but I don't want to claim that we're the first to do this. I'm pleased to have medical historians in the audience, because this is the earliest example I can give you of financial incentives to improve quality, but if anybody can give me one earlier, I will be very pleased. So this nasty looking chap is the Emperor of Babylon in the 1700s BC, and if you go to the Louvre in Paris, you will see one of these stone tablets in which the administrative rules of his empire were written down in whatever script the Babylonians used at the time, displaying my ignorance. Anyway, if you read down this column, and many copies of this column were made and distributed throughout the empire, so people knew what the rules were, you will find the first example of pay for performance. that if a doctor has treated the abscess of an eye of a gentleman and has cured the eye, he shall take 10 shekels of silver. So you can see that old Hammurabi was quite an innovator in terms of pay performance. I might say he was also an innovator in terms of patient safety, because if you read down a little bit further, you read that if a doctor has opened the abscess of an eye of a gentleman and has caused the loss of the eye, the doctor's fingers shall be cut off. So, with that background, a decade or so ago, we introduced pay for performance in primary care in the UK. And the background to this was that a large increase in NHS funding was announced in 2009 by Tony Blair, who said that he wanted to bring healthcare spending up to mid-European levels in the UK. And the British Medical Association and the Ministry of Health had privately agreed that GPs needed a large pay rise. And the reason for that was the recruitment to general practice at the time was very poor, and there was real difficulty in understanding how they were going to get enough GPs. But the BMA had to offer something in return, and the BMA decided to offer quality to convince the Treasury that they weren't just giving GPs something for nothing. And so was agreed in 2004 what's called the Quality and Outcomes Framework, sometimes abbreviated to QOF, which was incentives for family doctors linked to a complex set of quality indicators. £2 billion of additional funding was provided for that, so the GPs did indeed get a good pay rise. And there were quality indicators that related to clinical care, to practice organisation and patient experience. Now, it's probably important to realise, those of you who don't, that GPs in this country are and always have been private. So GPs essentially run small businesses deriving the great majority of their income from the NHS. So they bring in income from the NHS, they have expenses to pay for their staff and their premises, and the profit from the business is what they take home. So they're not salaried in the way that hospital doctors are. So this incentive scheme came in with a large amount of money and attached to a large number of conditions. So the conditions were somewhat smaller when they came in, but now if you look at this framework, which still operates, you will find that quality of care for all these conditions has some sort of incentive attached to it. And for those of you who are not familiar with it, let me give you an example of the way in which it works. Here are two examples of the indicators that are tied to payment. So the first indicator is the percentage of registered patients, and GPs have registered lists of patients, percentage of registered patients aged 45 or over who have a record of blood pressure being recorded in the preceding 5 years. Now, it's generally understood that it's a good thing to check people's blood pressure every now and then to identify people who might need treatment. And GPs were given an incentive that they get 1 point if they manage that for 50% of their patients, and a sliding scale up to 15 points if they manage that for 90% of their patients, and points translate into pounds. So that's a process measure, whether you can be reminded to check the blood pressure of people when they come in for some other reason. The second indicator is a slightly more complicated one, and this is the percentage of people with diabetes whose last cholesterol, which has to have been measured in the last 12 months, is 5 millimoles per litre or less. So there are guidelines that say it's a good thing if people with diabetes keep their cholesterol down, and there are things that GPs can do about that by prescribing drugs that lower cholesterol. So if the GP manages that for 40% of his diabetic patients, he gets 1 point, and a sliding scale up to, I think that should say 16 points if he manages it for 75% of his patients. So an incentive now not just to take somebody's blood pressure, but to try and get the patient to do things. All the data are extracted automatically from electronic records from GPs, and you may not be aware that your data is sucked out by the government every night from GP records to populate this database, and data drives payments. Diagnoses have to be coded in a way that will be understood by the computers, by GPs or by their nurses, and there's no restriction on who carries out the tasks to get these worthy things done. However, individual patients can be excluded from the quality calculation by their GP, and that's called exception reporting, because nobody ever imagined that a guideline developed by NICE or some other worthy organisation was supposed to apply to every patient that sits in front of a GP. It wouldn't make sense to be trying to lower the cholesterol of a diabetic patient who is dying of lung cancer, for example. So GPs are allowed to say, that indicator doesn't apply to that patient, take them out of the calculation. And it's been an article of faith of recent governments that all information on quality of care should be publicly available. And so here's a website which you could go to with my own practice in Cambridge that I worked out till very recently, and you can see what proportion of these various indicators we've achieved for the various conditions. And I've obviously showed you a slide here where everything seems to be 90% or more, because I wouldn't show you anything else, would I? So what difference did this make? Well, practices reorganized. They were around about 40% introduced, had electronic records before this started, and overnight that went up to 100%. Well, not a surprise, because they were getting a 20 or 25% of their income dependent on being able to produce these data. They employed more nurses, there was more systematic care for chronic diseases, and they had more administrative costs. And how did they do? Well, in the first year, this is the distribution of points that they could score on this system. The maximum was 1,050, and you'll see that most of them did pretty well. They got most of the money that was going straight away. Caused a bit of an embarrassment to the government, because they'd estimated, done their calculations on GPs getting an average of 750 points in the first year. So there was a bit of a funding gap to start off with. But did it actually make any difference? Well, so here's a slightly complex slide in which we looked at a representative sample of practices across the country back in 1998, then before the QOF was introduced, after it was introduced, and a few years later. And what you can see on the left-hand side is essentially quality score for 3 conditions. And if you look at heart disease, which is in the red line, quality of care for heart disease was already increasing pretty rapidly before QOF came in, continued at approximately the same rate, and plateaued. If you look at the yellow and the green lines, which are for diabetes and asthma, they were also improving, not quite so rapidly. There was a kick up in the rate of improvement of quality of care, again, then plateauing. So if you look at that graph, you might think that the quality incentives, or the financial incentives, had not made a huge difference. And you'd probably be right. Though I don't want to be too negative, because if you look at, and I've taken 2 indicators here because they're actually probably quite good indicators that might be related to patient outcomes over that whole period of time, you will see that from 1998 to 2007, the proportion of patients, this is people with coronary heart disease, with controlled blood pressure went up from 48 to 83%. And likewise, people with heart disease with controlled cholesterol up from 17 to 80%. Those are gigantic improvements in quality of care that actually probably across the system no other country in the world has achieved. But it wasn't all due to financial incentives, because many of you who are clinicians in the room will be aware that over that period of time, the UK government had introduced a whole range of measures to try and improve quality of care, from national guidelines, public reporting of data on quality of care, annual appraisal for all doctors in the NHS, and financial incentives. And if this could be summarised as anything, it's the literature shows that there's no single magic bullet for improving quality of care. You need multiple interventions sustained over time. People worried a lot about whether this financial scheme would impact on inequalities, and the reason is very simple, is that would it be that practices in affluent areas would basically find it much easier to meet these targets than practices in deprived areas, because their patients are more compliant, would come in when they were asked to come in for checks and so forth. This actually turned out not on the whole, it's a bit of an oversimplification, to be the case. And this graph shows you quality scores for, it's a scatter plot of all 8,000 general practices in the country against deprivation score, with the affluent practices at the left-hand end, and the more deprived practices at the right-hand end. And you can see from the linear regression line that scores are slightly lower in the very deprived areas. But actually the difference is not very much, and the difference actually almost had gone by the 3rd year of this new scheme. So, well, maybe it's not looking too bad so far. A modest impact of the financial incentives on improving quality, consistent with no magic bullet for quality improvement, and maybe inequalities in the delivery of care might even have reduced. But were there some negative effects on unincentivized aspects of care, and were there unintended consequences? So let me talk about unincentivized aspects of care first, because what you will immediately realise is this depends entirely on things that can be measured. So the measurable things become the important things. So let me describe a consultation to you, and I want you to just think about how this consultation might have been measured. This is Archie Cochrane, who many of you will be familiar with, is memorised in the Cochrane collaboration that seeks to establish the evidence base for interventions. Well, Archie was an army doctor in the Second World War, and he was captured by the Germans and spent several years in a prisoner of war camp where he was the only doctor. And in this extract from his autobiography, he describes an episode of care for a Russian soldier. And as I read it, just think about how you could measure the quality of care of this interaction. The ward was full, so I put him in my room as he was moribund and screaming, and I didn't want to wake the ward. I examined him. He had an obvious gross bilateral cavitation and a severe pleural rub. I thought the latter was the cause of the pain and screaming. I had no morphia, just aspirin, which had no effect. I felt desperate. I knew very little Russian, and there was no one on the ward who did. I finally instinctively sat down on the bed and took him in my arms, and the screaming stopped almost immediately. He died peacefully in my arms a few hours later. It was not the pleurisy that caused the screaming, but loneliness. I was ashamed of my misdiagnosis, and I kept my story secret. So that's a powerful story that makes you realize how much more there is to medicine than giving pills. So we have a real problem that we can measure some aspects of medical care, but maybe not the ones which may be most important to our patients at times. Now here's a more rather parochial and numeric example, because I'm a quantitative researcher. We try to look at negative impacts of the quality and outcomes framework, and here's an example from a paper which we published a little while ago, where we looked at the impact of the scheme on, first of all, this is treatment incentives, which we were able to identify in a large database of over 500,000 electronic medical records. And what we showed for these treatment indicators was much what I've showed you before. There was a bit of an increase in quality in the first year, which had plateaued somewhat by the third year of the incentive scheme. But when we then looked at treatment indicators which were not incentivized as part of the scheme, there was a significant reduction in quality of care. Well, there was a significant reduction in the rate of change of improvement, because in fact all things were getting better slowly, but there was clearly a difference between those incentive indicators which were incentivized and not. So you can see some detrimental impact of the incentive scheme on quality of care for things that were not incentivized. And what about the actual behavior of doctors themselves? Well, here's something that I think many people in the room may be familiar with. At the time, it was quite difficult to get an appointment to see your doctor. Many people had to wait a week or even 2 weeks to get an appointment. And so an indicator was introduced in the scheme that gave an incentive to practices that could see their patients within 48 hours. The response of many GPs to that was something called advanced access, where they offered unlimited appointments on the day, but basically didn't let people book ahead. And that meant that their target had been met, but paradoxically, patients found it harder to make appointments. And everybody realized this was what was going on. Well, except one person. And this illustrates why politicians hate doing live television broadcasts. Now, if you ever wondered why in election debates politicians are so nervous about anything that's unscripted, that's why, because they really, really don't like that happening. So before closing, I want to, and lest you should think that this discussion is just about whether financial incentives are the right way to pay doctors or not, I want you to just think about the alternatives. And this is the only bit of economic theory I know. Are there any economists in the room, by the way? Oh dear. Okay, well, this is a GP's view of economic theory then. So there are basically 4 ways that you can pay doctors. You can either give them give them a salary, in which case their pay is independent of their workload or the quality of that work. You can pay them on what is called capitation, in which the pay is determined by the number of people on the doctor's list. You can use what is the commonest method of paying doctors around the world, which is fee for service. You pay them for doing particular things, item for service payments, or you can pay them on quality, may pay them for meeting certain quality targets. So my question is, what would these four payment systems give you if you didn't rely on the doctor's innate professionalism? And the answer to that is that salaried doctors would do as little as possible for as few people as possible. Capitated doctors would do as little as possible for as many people as possible. Doctors paid on fee for service would do as much as possible, whether or not it helped the patient. And doctors paid on quality would carry out a limited range of highly commendable tasks, but would do nothing else. Now, the point of those slides is that there is no perfect system of paying for medical care, that all systems can have unintended consequences, and therefore we rely greatly on the internal motivation and professionalism of doctors, and it's therefore very important that payment systems or incentives or markets do not undermine that innate professionalism of doctors, or else you will increase the risk of those sorts of perverse consequences. So the questions which I think we might discuss, and the ethicists among you may bring somewhat more thoughtful perspectives to, are: is there anything special about using financial incentives to close this quality gap? And do you see any problem in the way that doctors have responded to financial incentives? Have patients got sucked without consent into a medical machine that gives them pills for ills that they didn't know they had? Or indeed, should they be celebrating the long and active lives that they're leading as a result? Or the epidemiologists among you might ask whether they are. And just thinking for a second about evidence-based medicine, which I suppose is at the foundation of all this, because these are based on supposed evidence-based guidelines of things that will be good for populations of patients, which Mark Tonelli quite nicely describes in saying that in evidence-based medicine, the individuality of patients tends to be devalued, with the focus of clinical practice being subtly shifted away from the care of individuals towards the care of populations, and the complex nature of sound clinical judgment not being fully appreciated. So those are some of the things which I think we could discuss. I look forward to that discussion. Thank you.
Thank you, Martin. Some of what you said fits very nicely with what Joshua was saying before. So, some responses to those questions.
How do you actually know that it is the financial incentives that have an impact on the quality now? It's not ending up on other medication people, or that these improved medicines that have actually created better care?
Well, the answer is that you don't. And one of the things which frustrates policy researchers like me is that people won't do randomized controlled trials of policy interventions in this country, because so one of the key issues in that, and it occurs, it's one that perplexes people all around the world, is most commonly financial incentive schemes of this type are brought in at the same time as public reporting of information on quality of care. Now, doctors mind about their reputations. So could it be that simply publishing the information about quality of care would have had the same impact without spending all that money? And broadly speaking, we don't know the answer to that question. Well, no, not broadly speaking, we don't know the answer to that question. Certainly, I've been cautious in ascribing improvements in quality to the financial incentives, but I did give you examples of conditions which already had a tremendous amount of attention being paid to them, heart disease and diabetes as examples. It may be that the incentives had more impact on some things which were really Cinderella areas. So, for example, there was an incentive in the scheme is to do an annual checkup on people with learning disability. Now, that's a group of people who have been pretty comprehensively ignored by the medical profession, And without saying anything about the effectiveness of those checks, maybe the fact that GPs had to sit down with their patients with learning disability once a year and think, are your needs being met, might have had more difference. But certainly people who continue to believe that financial incentives will be the answer to quality improvement, that's not the case.
I don't know, it's maybe a naive question, and I'm not a GP, I'm from a hospital background. But I'm aware that the salaried GP is becoming an increasingly preferred option for GPs. Are we at a point where we can compare the outcome from people who are cared for by salaried GPs and those who are cared for by people whose income depends on services?
No, unfortunately, absolutely not, because almost all salaried GPs work within a practice where there are sharing partners. So there are a very small number of practices where they're fully salaried, such as the small number of practices owned by private corporations, but they're tiny in number and very special. So no, we don't know the answer to that question, and there's a big question at the moment is, would it be better if GPs became salaried? And I think that there's no simple answer to that question. I think that the small business nature of the general practice has in some ways served the NHS very well. There's been entrepreneurialism, innovation, which is hard to see in some, I have to say, my very disempowered hospital colleagues who don't feel able to change their systems. But equally, there are disadvantages in terms of governance and all sorts of other things to do with the independent contractor status.
Thank you. As a medical student, a junior doctor, subsequently as a medical teacher, I didn't come across any medical students, and very, very few young doctors who were motivated by profit. Subsequently, throughout my fairly long career, I've come across more and more doctors who are quite clearly unmotivated by profit. So I reached the conclusion after many years in practice that a child's likelihood of having their tonsils ripped out unnecessarily was largely related to their parents' membership of Bupa rather than any clinical need. And my question is, how on earth do you maintain the professionalism, albeit in maybe a small proportion of the medical profession? How do you maintain the professionalism, which is quite clearly apparent at the start of medical careers and seems to be diluted or corrupted throughout during the course of that?
And indeed, one of the questions which researchers have tried to answer is how soon that starts going, and is it even during medical school that we have very, very bright people with great aspirations and they've turned into some sort of machine by the time they get to the end of medical school? I think the simple answer to your question, and there clearly isn't a simple answer, is that we operate under a whole set of incentives. So there are professional incentives to do the things that we believe we should do from a professional perspective. There are managerial perspectives, which particularly in hospital practice can be very intense indeed. And there are financial and other incentives. And I think the key to answering your question is that those other incentives are fully aligned with the professional incentives. I think the time when you are most likely to get perverse consequences is when the managerial financial incentives cut across what are the innate professional incentives. And that's where you really risk damaging professional morale. A simple answer to a much more complex question.
Thanks very much for that, Martin. As your Blair clip seems to illustrate, is one of the main hurdles to patient care not actually the politicisation of medicine and healthcare, rather than whether or not we offer various financial incentives? And shouldn't the BMA and the Royal Medical Colleges and the other interest groups actually be doing more to actively resist the shifting political winds and the next new ridiculous target that's introduced? And also, in particular, the creation of demand for especially primary care services or emergency services where demand never even existed before the politicians suggested it was required.
But politicians are not malevolent. So the situation that Discuss. So the situation that Blair was trying to address was that people had to wait too long to see the doctor. Okay, the method they introduced to try and deal with it turned out to have adverse consequences. A problem that they are dealing with at the moment is that they believe that people would like to see their GP 7 days a week. If they force the implementation of that, there will be adverse consequences to that. Likewise, 7-day hospitals. So it isn't that I don't think the motivation of politicians is malevolent. It's just that they try and provide simple solutions to what are very complex problems. And not only that, they have incredibly short timescales. So ministers, and our current minister is an exception, but ministers tend to be in their jobs for relatively short periods of time, for maybe 3 or 4 years, and whether they go up or down at the end of their ministry depends on whether they've shown that they've done something. So there is this tremendous impatience by politicians, and of course the corollary of that, impatience with academics like me who said, I'll give you the answer, but it'll be in about 7 years' time.
I'm just going to take 2 more questions. The gentleman was next to Bill. Well, in which case, Andrew.
Thank you very much, Andrew Dunn. So 2 responses and a quick comment. Firstly, the initial incentive for the cloth, of course, was to give GPs more money and therefore increase recruitment. Doesn't seem to have worked very well in terms of recruitment, but that's a separate issue. Responding to my colleague behind me, I was the chief medical officer of the group for 16 years, and as a commissioner, I was personally responsible for bringing in really tight guidelines about not paying for people who were doing surgery which shouldn't have tonsillectomy, for example, I might say, which was not shown to be effective, and I often been accused of this by GP surgeons. But the general comment I was going to make was more about your point about compassion and the importance of that in surgery, and I really think this is really important. The old arts of medicine, time, touch and compassion are so important. And to be provocative slightly, I think the people who do this best and who are paid for it are alternative medicine practitioners. I think they don't have much more to offer than time, touch and compassion, but my goodness, millions of people around the world go and pay for their time, touch and compassion. It's an enhanced placebo effect perhaps, and some of the other stuff is just charlatan stuff. But I think it is important that people are looking for time, touch and compassion and are prepared to pay.
Yeah, well, 2 quick comments to reply. First of all, you're absolutely right, but of course the alternative medicine practitioners give a lot of time. So they give 3/4 of an hour or an hour. And that's something that looks difficult to do in the NHS. I don't think I agree with your first comment. I think the financial incentives did work, because for a time GP recruitment went up quite smartly, and longitudinal surveys which were done of GP job satisfaction also showed a marked increase in job satisfaction. There was then a problem in that, back to politics, the government thought that GPs would take this extra money and invest it in their practices. The BMA's perspective, the BMA had always, so the government's starting position was, quality is rubbish in general practice, it's not going to cost us too much if we introduce these incentives. BMA's position had always been, actually, doctors have been improving quality in these areas for quite a long time by investing in their own practices out of their own pockets. So they're going to meet these targets pretty quickly, and indeed they did. So the GPs didn't need to invest heavily in their practices to get the money, so they pocketed most of it. Government were pretty cross about this. I think they were probably actually cross with themselves. But as a consequence, over the last 10 years, they have progressively clawed back that increase in income. So GPs in the last 5 or 6 years have had a real year-on-year pay cut, which is one of the reasons that they're now so grumpy to our medical students, who then don't want to go into general practice.
My final question.
Thank you very much. Can you expand what you mean by unincentivized, indicators? Because, I've been looking at research which shows that doctors, including GPs, neglect the existential dimension of suffering and illness. And I can think of many consultations I've had where I've tried to attend to that, but it would be very difficult for anything on the computer that
Yeah,
needs,
yes.
you know, a real code for that.
Well, perhaps I mean, I think, I mean, I gave you a very sort of instrumental example of treatment variables, but a much, much better example and perhaps a more common example would be if you've got you come and see me as a patient, and I'm aware at the start of the consultation that you've not had your blood pressure checked for 10 years. You come and you see me about a sore throat, and we deal with the sore throat, and there's then 2 or 3 minutes left. And looking at you, I can sense that you look a bit upset. You might even have a few tears welling up. And I have a decision to make at that point, to take your blood pressure or to say, is there anything else that's bothering you? So you can see how that consultation could go dramatically wrong by taking your blood pressure. Or it saves you from having a stroke.
Right. Thank you, Martin, for that excellent presentation.